All right, tell me more. What should I expect in the exam?
So first, I will tell you about the risks.
Mm-hmm.
Known and associated risks. The dose of radiation your wife will be receiving is relatively small, but sometimes your wife may need to stop taking certain medications before she has a thyroid scan. And
Mm-hmm.
it's very important that you need to tell the staff if your wife was pregnant or breastfeeding, because the radiation dose is not good for the fetus.
Pregnant, breastfeeding. You should pronounce those words carefully.
Breastfeeding. And maybe your wife have not had any other radio procedures that require the injection of the iodine at least 8 weeks. If your wife...
You mean iodine, right?
Iodine.
Yes. Okay.
If your wife has had a test using iodine contrast medium, your wife's thyroid scan may need to be rebooked for a later time.
Okay, keep going.
And about the benefits, the thyroid scan is performed so the doctor can determine which parts of the thyroid gland are working properly or overactive or underactive.
Mm-hmm.
The second, it can also help in distinguishing between benign and malignant.
Mm-hmm.
Third, thyroid scan also gives some information about the size and the shape of the thyroid gland. So that's why I choose thyroid scan for your wife.
Okay. Well, I think it's okay but what is the cost of this imaging study? How much is that? How much it cost?
The cost is 80%. 80%.
The cost of 80% of what? %80 of what?
It's decreasing in the cold nodule and hot nodule.
You mean it distinguish between the cold and hot nodules? Okay, but I'm asking you how much this test costs. How much?
It's so expensive. It's so expensive, but I don't know exactly how much.
Well, you as a doctor, you don't have to know the exact test, but this is how I would answer. This test is very expensive, like you said. The exact cost, I will let my hospital staff. I'd like to have my nurse come back and discuss with you later, but it is expensive. Okay, so let's stop right here and let me go back to. But class today lesson for all you is number one, you should know how much each test costs. You can Google, you can do whatever you want. You don't have to know exact the cost, but some idea, because I just say somebody will pay it, whether you, the patient, or the government, or the hospital. So you should know that basic rules. Whenever you order something, follow the result and its cost. So that keep in mind, because I'm focused on this because a lot of doctors don't train well in business and also in economy. And I mean, in the US, we order so many tests and actually a lot of them are waste money. I'm sure it happened in Vietnam too. So know basic cost. And you can go very basic, but actually it costs about $5 to $6 in the US. Ultrasound about $80, $60. CT about $400 or $500. MRI about $2,000. So, and then it's a nuclear medicine about $700, $8. And then PET CT about $3,000. Okay, so that's the cost. And I will tell you, you can go to any hospital, but that's the average cost. Why? Because you have that in mind later on when you pick a modality, because you will not be a student forever, I hope, right? Some of you will finish soon, and then you go out there and you practice medicine. You have to find a reasonable, I say a reasonable test, because sometimes you know that CT is better. However, if the patient is so poor, and if your clinical judgment is enough, so an X-ray should be sufficient. Does it make sense? So the patient is really poor, and if your clinical thing is pneumonia, and that's it, you don't need any further tests to confirm, you don't need a CT. Does it make sense? So go back to your case. This is a very hard test, and I'm sorry you picked this case. But I challenge everyone from this class to explain this in the lay term. It's very difficult to explain it. So this is how I would explain to you a nuclear medicine of thyroid, okay? So, Mr., your wife have a nodule here in the thyroid gland. This gland monitor her energy level and her metabolites. That's how she eats, how she digests food. A disorder on this gland can impact to her functions. In order to evaluate a function of this important gland, we do a nuclear medicine study. And yet, this is the same nuclear medicine term that Kim Jong-un used. But this is not Kim Jong-un, this is not North Korea. This nuclear medicine we use is very, very, very light. It's nothing to compare with whatever nuclear medicine you heard on TV. So you, as a doctor, you have to assure the patient that this is very, very small amount. In fact, the tracer or the radio tracer in this particular test is nothing compared to the uranium or whatever radio tracer they use there. So your job as doctor, number one, to reassure the patient that, yes, it sounds scary, but it's a very small and tiny amount, okay? So that will assure the patient. So secondly, you said, and this is how it works, because your thyroid constantly pick up things from the blood, so this nuclear medicine, when we inject into your blood, it travels around, and when it goes to the gland, your thyroid gland will pick it up. And when it pick it up, we look under the machine and it will light up on the screen like this. And that's why we say it's hot or cold, because if they pick up a lot of signal or a lot of dose, it becomes cold or hot, and depends on that, we will interpret the test as negative or positive. Does it make sense? Is it easy? So as a doctor, one of your key, and I also recorded a YouTube video, so every after today, you should listen to it and try to explain a very simple layman terms for your patient for each test. This is so crucial, because if the patient don't understand those tests, they don't want to order, and for you as a doctor, you fail to convince the patient to do the test. And this is a very necessary and important test. Okay, and lastly, yes, breastfeeding. Try to pronounce those breastfeeding, pregnant. Those terms are important. Okay, all right. Thank you. Any questions so far from the class? So I have your name here too. All right, next one, please.
Uh, 18 years old male professional soccer player was hit on the lateral left knee. What imaging modality you will do? So
right.
the first, yeah.
Yes,
so the first thing, I need to take. I think that I need to explain to the patient and take an X-ray for the patient. So the reason I take X-ray because the patient had an accident while he playing soccer, and he had a tumor in his knee. So the problem may be, the fracture of the bone and the dislocation of the joints, or the patient have the problem with soft tissue or the blood pressure. So the X-rays will tell me that the patient have a problem with the fracture of the bone and dislocation of the joints. And X-ray is very cheap and it's very easy to do, so it not take too long time. So it's easy to look at the problem with the patient and have reasonable treatment for the patient. Okay. The second thing I might do, I can take the ultrasound, because the ultrasound in this situation will help me to look at, some fluid inside of the knee. It can tell me there's a problem with the tendon or ligament, or some problem with the blood pressure damage. The ultrasound is also very cheap. It's just about 100 VND, and it's we call it non-invasive image. So it's not, it doesn't have any radiation. So it's very good for the patient.
Good, I like it. Okay. How about when you will order an MRI of the knee?
I think that MRI, it also, we can do the MRI, but it's not necessary in this situation because like the patient.
So just want to make sure we speak in the same language, because this is medical English. So say MRI, because this is how we order MRI here. I know that people debating which term, it's up to you there, but this is medical English. So just follow the conventional medical English, MRI. Okay, so when would you do an MRI versus an ultrasound?
So compared to the ultrasound, the MRI, it's also to see there's a problem with the soft tissue injury and the tendon or the ligament, but in acute injury, we shouldn't use the MRI, because MRI will cost the patient a lot of money. And in this situation, the ultrasound can do accurate as MRI. So I think the patient better to take ultrasound.
Good. I agree. In this case, this ultrasound and X-ray is enough. But when would you use CT of the knee versus MRI and ultrasound? When would you like to do a CT of the knee?
The CT is okay, because the CT scan you can do in this situation is much better compared to the X-ray, because it's also use the radiation light X-ray. But the first thing you need to know is that the CT scan, the computer tomography would take you a lot of money. And the second thing is it takes a lot of time. It takes a longer time than the X-ray. So I need to see. I need to see that's the problem with your bone right away, so that I have reasonable. I need to have the surgery or something else. I need to have the immediately treatment for you. So the X-ray will quickly and easier for me to do it.
Sure.
Okay.
Just for general class information, when you will do a CT of the knee, in general, when?
Like the middle.
Because somebody will do a CT of the knee, right? When? In what situation you do a CT of the knee? When? So let me share with you this story. So you have an answer? When? And in what case?
You ask me or you ask class?
Yes, I'm asking you.
I think in some situation that we can take the CT scan. For example, the patient have the problem with the brain, or the patient may have the embolism or on the blood pressure of the brain, or some soft tissue like inside of the chest, or the patient have the cancer, or maybe some cancer in the mediastinum.
Okay.
The patient have a problem.
If you bring up the cancer, and so between cancer, CT and MRI, which one is better?
It depends. I think I cannot. I think it depends on have cancer. It depends on what kind of cancer. And the brain cancer maybe MRI is much better, but some cancer in the chest, I think that the CT scan is much better. I'm not sure.
Well, you're correct, but let me tell you, and the class too, there are situations that you will do CT of the knee. And in that case, it's a trauma case. It's accidents, like car accidents, traumas. Why? Because CT of the knee, you will evaluate the whole bone. And this is also, you do this, you have a coordination that you can do knee surgery. So the orthopedic surgeon, they know, when they look at the CT image, they know which damage. And think about fracture, accident, car, okay? So those things, you go with CT because it's fast. You go to our trauma center, they will scan your knees, scan your legs, and also scan your hips. And that's how the trauma surgeon or the orthopedic surgeons, when we look together, we know which way we're gonna fix. So that's answer your questions. And for your case, go back to your case, this is a professional soccer player. I completely agree. You can do X-rays, you can do a bedside ultrasound, you can do portable ultrasound, bring to the field and do a quick tendons evaluation to check the anterior crucial ligament versus the PCL, the posterior crucial ligaments, and also the lateral ligaments. Now, MRI is more sensitive for tumor. So for the class, you should know that tumor, if you want to evaluate MRI. Why? Because you need contrast. And why you need contrast? Tumor or cancer, they consume a lot of blood, right? So when you have blood in this cancer cell, it will bright up like firework. It looks beautiful. Unfortunately, it doesn't look, it's not beautiful for the patient, but for you, I look at it, I say, gorgeous, look at the brain tumor, it's bright up. And that is contrast. So think whenever you see cancer, okay, think about cancer and you want to evaluate, think about MRI, because that's the best one, and this is soft tissue. All right, so thank you very much. Let's move on to the next one, and let's go a little bit faster. So let's pose the next case. Any comments, Kilo? All right, student, tell me your name and your case number.
My name is Trúc, and my case is number 2.
Okay.
21 female presented with a severe lower abdominal pain and not having period for 2 months. So,
well, first of all, what is your diagnosis? What is your diagnosis? What she have?
I think she has ectopic pregnancy.
Okay, she has ectopic pregnancy. Excellent. What level are you? What year are you? Are you 5th year, 6th year, or 1st year? Okay. I'm very impressed if you're 1st year and you make ectopic pregnancy diagnosis. Okay. All right. Tell me what modalities, what type of imaging, what medical imaging you would use in this case?
I will,
speak louder.
I will use transvaginal ultrasound. Transvaginal. This is like an equipment that we will put in the vagina, and it shows the image on the organ like the uterus and ovary. And yeah, and it's also show the image of other organ like and the kidney or the bladder. Yes, and in this case, I use the transvaginal ultrasound, and in case transvaginal. If she has ectopic pregnancy, and I will see there is no gestational sac in the uterine, but it will locate on the other side, for example, like in the fallopian tube, or in the ovary. Yeah.
So how would you convince a 21 years old girl this is something that will make you very discomfort? How would you convince her to do this test?
I will tell.
So she will ask you this, doctor, did you ever have this test before? What would you do?
Not
speak loud.
It's not pain, but it may cause her feel not comfortable, and it's necessary because in this case, if she has the rupture ectopic pregnancy, it's an emergency, so I need to use this ultrasound, and it doesn't expensive, and it doesn't take long time to check.
It is not expensive. You won't say it doesn't, because this is an objective after a word. So it is not expensive. Now, a lot of questions they will ask you, did you have this test before, doctor? And how would you explain to your patient?
Could you ask again?
Doctor, did you have this test before?
Oh, sorry, it's because the connection.
I understood. So I'm asking you, doctor, did you have this test before?
I sorry, could you ask again, please?
Have you ever done the test on yourself?
No, I haven't.
So you haven't. So why are you telling me this is not discomfort?
Because I have done for many patients, and they just said that it's it's not pain, but just a little in comfort.
Very good. I like it. So you have to use this argument. You will say, well, first of all, I don't have it myself. However, I've done this test so many in my patients, and we tell them what we'd like to do, and many of them don't have anything, or they feel very comfortable. Okay, so that's how you explain, and I like you to this way. So you did it before. You do the test. Yes.
No.
Okay, so I challenge all of you students there. You should do this. It's another fun test, but you should know that. Why? Because the prop is about this long. Okay, and a lot of times you have to use a protection. I mean, many of them use condom, but you can use any type of bag. And the key work about this test, because when you do this, you always ask for the patient response. Some of them will have extremely abdominal pain. So I see students don't care. They just put in and try, and then the patient jump to the floor. And this is very bad. Okay, I will tell you, nobody want to do the test again. So watch the patient respond. In general, if you do ultrasound in anything, see how the patient feel. Even if you scan in the abdomen, it's very benign, but it's jelly, it's cold, and you expose somebody. So this is not a comfort test at all. Think about it. And if you think this in your mind, you have a better explanations, and the patient will trust you. And that's the key in communication. Okay? Any questions?
Yeah. No.
Okay, good. Let me ask you one more challenge question. If the patient refuse the test, she absolutely don't want anything put into her vagina, what other tests you will recommend?
First, I will check her during a pregnancy test to see if she's pregnant or not. And then I will check the serum beta HCG.
So class, if somebody present to your emergency room, you do two things at the same time. You do pregnancy test, you do the quantity test. You don't wait, the test is positive, okay? This is how medicine in practical side. I'm teaching you a lot of practical side of medicine because the book is one thing, but you go out there, practice medicine, if you really want to make a good service, do two tests at the same time. Because it's negative, it's fine. But the positive, you have the quant, that means how much, because the level, right, accordingly to your gestation age if there's a pregnancies. Make sense? Okay. The other one is if the patient absolutely have no this test, you still can do a trans-abdominal test. This is a very low sensitivity, but it's better than nothing. You can say, okay, miss, if you absolutely don't want the test, yes, I will ask. And good news is Vietnamese women are very small. They thin. They're not American. American, I won't recommend this. American like this. I mean, I cannot see anything with that. So it's, don't get me wrong, okay? But for Vietnamese, for Asians, a lot of time we can look at that. It's quite easy to look for trans-abdominal versus trans-vaginal. Okay, so go home and study the difference between trans-vaginal and trans-abdominal. Okay, class, make sure that you remember those two tests. And especially for those going to be future OBGYNs, this is your bread and butter. This is how you make a living. So you should be familiar with both tests. Any questions, Joe?
No.
Okay, good. Move on to the next one. Thanks. By the way, class, where is the camera that I can see everyone, because I like to make sure you guys don't sleep. I don't let my students sleep while in my lecture. Okay. Well, I do know that people voted who's the nicest doctor. Like I think Dr. Mindo, it's probably the nicest guy. Right, Jilong?
Yeah.
Okay. I don't know, I'm become mean.
Hello, class.
Okay, come on, guys. We don't have a lot of time, and I like you to be more efficient. So I have 4 cases done. All right.
Yes, hello. My name is Naman.
Good job. Go ahead.
Yeah.
What case are you presenting?
Yes, my case is number 6, about a 32 female just came back from Vietnam in a long flight, presented with shortness of breath and tachycardia.
All right.
And
so
first,
what is your diagnosis?
Yes. First thing, I think she's have maybe she have pulmonary embolism, and the other things maybe the deep vein thrombosis.
Okay, so
it's all because she just a very long flight on the airplane, and this is a good condition to have the deep vein thrombosis, because she sits very long time and doesn't move. Yes, and because of the shortness of breath, and she has the fast heartbeat, So I also think of the pulmonary embolism.
All right. Based on what? Based on what criteria? You think she have PE, you think she have DVT, but I'm asking you based on what criteria?
Signal problem again.
Okay. Hello? All right, are you back?
Okay, yes, the connection is very low. I'm sorry. Yes.
That's okay. There's a shark out there and they buy the cable. All right. My question is, what is your diagnosis based on what criteria?
Repeat for me.
You told me that you think she have PE, and
Yes.
you think she has DVT based on what clinical symptoms or based on what criteria?
Yes, because the patients teachers have no any conditions, or I don't know if she has any heart disease or maybe the blood clot before. So I just have the general diagnosis based on the very long flight sitting. And other things because of the fast heartbeat and the shortness of breath, and maybe it's based on the changing of the atmosphere. So, yes.
Okay.
And yes, about the lab test, I think first I will give her ultrasound for the vein of the leg. Yeah, to find out if she has any blood clot, and maybe the presence of the blood clot. And the thing, the ultrasound is a low cost lab test, and it is also non-invasive screening, so she's will feel very comfortable, and it's no harmful for her health.
Good, I agree with that. I would go ahead start with ultrasound. What if your ultrasound is negative?
Can you repeat it? I can't hear clearly.
What if the ultrasound is negative? What would you do next?
Còn có một dấu chấm rồi. Em xuống phòng họp thử nha.
Okay, so what if the ultrasound has only, what if the ultrasound come back as negative?
Okay. Yes. Also, what is your last questions? I can hear clearly.
My last question is, what if the ultrasound result come back as negative? What would you do next?
Okay. If the results is negative, the next thing I will give is the CT of the pulmonary angiography. And I think it is a very high technique lab test, and it is a very good way to find if she has the pulmonary embolism, and because it's very expensive cost, and it required a contrast agent, and the patient will also exposed to the radiation. So I not really suggested that test.
Okay.
Yes.
Well, what if she has kidney failure and she cannot take contrast? What would you do?
Because okay, if she had a kidney failure, and I think I will do maybe I will do the MRI instead to find her problem.
MRI. Okay.
Yeah.
So let me hold you for the class. Class, anyone have different opinion? Come up here and join me.
Ca số 6. Case number 6. The PE long fly.
Okay, I may have some idea.
Okay, go ahead. What would you do?
Yes. If we suspect some pulmonary embolism, we can first do the heart ultrasound to find if there is any acute right heart failure.
Oh, good idea. I like it. Okay.
And if we can do the CT with the contrast, we can do the VQ scan.
Excellent. So let's go back to the first one. You said that the right heart failure, no, the right heart constraint on ultrasound. So what are you looking for on ultrasound?
Because if the patient has some embolism in the lung, so that will be the increased pressure to the right heart. So we will encounter some signs of like the right heart is going to work harder, increase the load. Yes.
Okay, excellent. Class, you should remember this because PE, acute PE, the blood clots stay in the artery. Remember your anatomy, this is called pulmonary arteries, the major one. And where it's coming from? It comes from the tricuspid, okay? And that comes from the right heart. So if there's a clot or blockage kind of further away, so the right heart, the right side of the heart has to work stronger or harder. And that's how you do bedside ultrasound. What you're looking for a right heart strain, like you mentioned earlier. You can see regurgitation. So that's the term that you're looking for. So basically, the mitral valve is on the left one with the left ventricle, and now we have the tricuspid valve, and then the pulmonary valve, and then the aortic valve. So if there is a right heart strain, you will see that on the side. And yes, VQ scan, ventilation perfusion scan, it's another technique that you can look for. I don't know how common VQ scan in Vietnam. Can anyone tell me?
I think the VQ scan is not very common in Vietnam. I just learned it by the textbook.
Okay, good. But I'll let you know what it is. That's good. Okay, so make sure students go home today and look at VQ scan. Okay, that's the correct term. What it does, let me explain to you in 30 seconds, is you match the blood and then the nuclear. So people would take a deep breath and they match if they really are perfusion and ventilation are the same. So that's negative. If there's mismatch, that's positive. So basically, just like you and your friend run parallel, okay? And if there's no blockage in one row, so the two of you start at the same time and at the same time. So you've done it if there's one road blocked, so your friend run and then he stopped it and you keep just you run and finish by yourself. So that's mismatch. Does it make sense? So that's an easy explanation of visual scan. All right, next case. And I like to make sure, class, if by the end of this, I like to make sure that you have some understanding about each modality. So that's the goal when we started. We do one more case and then we take a 5-minute break, okay? All right.
Sorry about this case. I think I have another diagnosis because when I read about this case, not entire the case, just the keywords. After a long flight, I think that if patient have a pneumothorax, because maybe she has hit the blast bubble is exploded and the air breathing will fill into her pleural cavity. Do you think of this is a reasonable diagnosis?
Yeah, I concur. In this case, you have to make sure, and if it's pneumothorax, what is the imaging modality you will do?
I think if pneumothorax is the exact condition in this patient, we have to offer a very simple imaging investigation, that is chest X-ray. And then we will see a line, I mean a black area in the pleural cavities. And we don't need to do more investigation and head on to the diagnosis is pneumothorax, right?
In this case, pneumothorax is under differential diagnosis, but it's not the most likely diagnosis. But let me tell you this. You do ultrasound, you do bedside ultrasound to rule out pneumothorax. It's better at higher sensitivity than chest X-ray. Why? Because if people have anterior posterior pneumothorax, right, and here my chest, and you take an X-ray, you won't see it. You see pneumothorax only on the apical side, on the bilateral lungs, on the upper one, and on the lateral side. On the anterior portion of your lung, if there is pneumothorax, ultrasound is a better one. In fact, when patient laying down, remember, go to emergency room, she laying down. So air go up, air go up. So air will go to the front of her chest. The best test for you actually do a bedside ultrasound, okay? And I like to make sure that you, in the future, you train this technology. I don't know how common, but I wish if I come to Vietnam one day, I will spend a whole day just for you guys to do bedside ultrasound. We will do a really fun. This is really easy technique, and every student should have or try it. Does it make sense? Have you heard about bedside ultrasound to evaluate pneumothorax? Yes or no? Class, have you heard about bedside ultrasound to evaluate pneumothorax? Yes or no? No? Okay, so bedside ultrasound it's a technique that you use a machine next to the patient. It's called bedside, and you're looking for pneumothorax. Okay, so I will send you a link to look for that. Anything else? Who's my next case?
To investigate the area is filled with fluid, and X-ray will handle with the air. Yes. So when I hear we use the sound for to investigate the chest and the lungs, is to kind of strange and unfamiliar.
That's right. Because you guys student. That's why I don't expect you know a lot. But I give you today idea with the article I just sent you. This ultrasound is what I'm trying to tell you, class, is there are newer modality, so a better technique, and X-ray. My guess is actually in the future, I don't know how many people will use X-ray, to be honest with you, because you go to emergency room, we scan you, we don't X-ray because it's much faster and it's more sensitive. And then with ultrasound, you can do a lot. You can look from I don't know how many students you know that you can look for intracranial pressure by ultrasound. This is just like a bonus lecture, but have anyone think about it? Or any class? If some of you will tell me you can measure the pressure inside the head by ultrasound, I will give you guys a ticket to well, let's do this way. I'll take you guys for dinner, okay, and I'll go to Vietnam. So if any of you, I challenge entire class, if any of you can tell me how to use ultrasound to evaluate the pressure inside the brain. Can anyone think? Have you heard about that? Because this is important. If the patient presents with headache, right, with meningitis or meningitis side, you want to look for the pressure inside the brain, or the pressure, the CSF opening pressure, right? When you do a lumbar puncture, you like to make sure that you measure the pressure. So I'm telling you, there's a technique to use ultrasound to evaluate the pressure of the brain. Is that amazing? Okay, so I will tell you, I'll send you a link, but this is how it works, okay? What we do is we do intraocular ultrasound. The patient will lay down, close their eye, you put the ultrasound probe right here, okay? And you look for the optic nerve. Remember, the optic nerve is connected to the brain in this part of the brain. So eye is brain, okay? I like to make sure you know your eye is your brain. If there is increased intrapressure in your brain, it also compresses on the optic nerve. So what happens is the fundus, or where the optic nerve come out, the arachnoid space surrounding by the optic nerve and also optic arteries and optic vein will be compressed. You measure that distance, and that distance will tell you how much the pressure is on the brain. How amazing. Okay, I send you guys a link and you guys can look for that. But the bottom line is ultrasound can do a lot, okay? So intraocular, any question? You look confused.
Not yet.
Okay. And this technique also true to look for high blood pressure. People present with emergency high blood pressure, you look for that. So this is a study, so you guys, this is the article from the NIH, and basically the accuracy of non-invasive intraocular pressure or optic nerve sheath diameter measurement to predict elevated intracranial pressure in meningitis. All right. All right, so who is my next one? Or is that too much information? You guys don't want to know this, or is that too much?
Hello, I'm the next one.
Sorry.
Yes.
Maybe after done this case, we take a rest.
Okay. Also after this case, we'll take a break. Go ahead, guys.
I will present the case number 15. So the 18 female virgin present with acne, weight, irregular menses, too much hair, and to do pelvic ultrasound. I think I will choose the transabdominal ultrasound because first the patient is still virgin.
Well, I have a good news for you. I think Dr. Wang Fu just joined us, and he's OBGYN. This is the perfect case for him to jump in. Okay, go ahead and tell me why you use transabdominal versus transvaginal. And this is 18 years old case, virgin. Okay, keep going.
So and and perform ultrasound. I think I want to looking for the change in adrenal glands or some problem with the ovaries.
Mm-hmm. Okay.
So
so you pick the abdominal route for this patient. Okay, and you're looking for change in the adrenal gland and then the ovaries. What is your suspect diagnosis?
I think the problem is the problem of the symptom. These symptoms is called hyperthyroidism. I read in some medical books, and they say the problem is of these symptoms was in cause of caused by the adrenal gland or the ovaries, because they may secrete too much hormone.
Okay. I think it's okay. I think this is a decision that a lot of doctors, you can do either way. But for transvaginal, at least here in the US, if you perform accordingly, it's still okay. Because one of the major concerns for this one is if the patient is a virgin, and if you insert a prop in, it will damage to her integrities. But this is a case that you as a doctor, you should explain to the patient the risk and the benefits, because if you do trans-abdominal, you will use a different props. I don't know if many of you know there's a 3 prop in ultrasound, actually 4, but the one that you usually use abdominal, it's the low frequency one, versus the high frequency is the transvaginals. Because of that, the quality of image of the abdomens, you look deeper organs, and sometimes it's not as good as the transvaginal, so you may miss other things. But Dr. Wang Fuho, can you hear us? Can you give our students some comments about the 2 different test approach, and how would you advise the patient?
Hello, everybody. Can you hear me?
Yes.
First, just a long break, 2 weeks break. Welcome everyone back. Just somehow I just got in, just touched into my specialty. And secondly, I meet my favorite student, Tung Tran. Okay. So I think what you need to do is ultrasound. Is ultrasound just another modality to help you with a diagnosis, but you don't use it solely to to come with the diagnosis. I've seen a lot of patients people from here to go back to Vietnam and visiting doctor. Everyone have an ultrasound, CT scan, everything. And secondly, I'm not offending Dr. Woon Tran, but in America, everyone will have some form of diagnostic like CT scan, MRI, PET scan, everything. So sometimes we make sure you not overuse, the diagnostic. And if, this case quite clearly look like the patient has polycystic ovarian syndrome, which is quite common in westernized, Western world, but in Vietnam, we don't see many. But when people migrate here, we've seen quite more common. We've seen the Vietnamese, girl grown up in, Western world. Go back to ultrasound. Ultrasound, we usually like low frequency through, the probe. We generate the wave, and the wave you're hitting, the structure and bounce back, and the computer will pick up the signal and generate the picture. Just imagine you're using, when in the world, in the ocean, how you pick up the submarine down in the bottom of the ocean. They generate a sonar wave and they hit the solid structure and bounce back to give us, the submarine underneath, in the ocean floor, so okay, they can destroy it. So ultrasound had limitation. Ultrasound good at looking some solid structures. So ultrasound depend on how much the wave can go. The ultrasound wave can penetrate through and hit in the structure you wanted, and echo back to your machine. In the people like in Vietnam, probably easier because they quite thin. Yeah, they're not obese. I'm not. It's obese, not obese like in America or Western world. So the sound wave doesn't have to penetrate too far to go to the structure you wanted. So ultrasound, probably abdominal ultrasound is not a major difficulty to do in thin people. But transvaginal ultrasound has been an evolutionized of the technique, which give us so much better the resolution, the picture, and the structure we want to look at, like Dr. Tran has said. Because we put the probe right next to the organ where we want to detect some abnormality in that. So abdominal vaginal ultrasound becomes very normal for us to do, especially when I do IVF. I have to do transvaginal ultrasound to pick up, looking for the egg follicles, and we do egg collection. And other thing, gynae with ultrasound, gynae is ectopic pregnancy is the best way to do. We do ultrasound, so easy to pick up. Ultrasound, most of the doctors have ultrasound in the surgery now because ultrasound doesn't cost a lot, and the machine getting smaller and resolution is getting better. Back to this case, when the girl had, virgin, probably I will not do transvaginal ultrasound scan because unless we really need, but in this case, we no way I'm going to put a probe into her vagina to do because I can break the hymen, and and also the litigation involved with how you chaperone, why you have to do it. And so ultrasound and picking up on this problem with this girl looked like she got polycystic ovarian syndrome. Just, I think in Vietnamese có hội chứng đa nang buồng trứng. So this one, just you have to do you have to go back to look at Amsterdam definition of polycystic ovarian syndrome. You're looking for biochemical. She got a clinical picture. You got irregular period, got acne, you got hirsutism. That's a part of it. Now you do the biochemistry, looking for androgens, looking at testosterone, sex hormone binding globulin. You're looking for free androgen index, looking for for the androstenediol, and looking for progesterone, other hormone, progesterone, estrogen, something. Androgens, I think Dung Tran mentioned about androgen. Yeah, probably from adrenal gland, probably yes, but how often you see adrenal gland, hyperplasia? It's not very common, but when you do the biochemical testing, look at the dihydro and androstenediol, you can pick up some sort of information about how the adrenal gland hyperplasia there. So I think probably I'm not going to into very, very, like more rare case, more like looking more common case. This is the ovary. You're looking at the ovary. So when you look at this case, you have to go back to see how I make a diagnosis. Should I use ultrasound alone to make my diagnosis? You got a clinical picture. You need biochemistry. Ultrasound looking for polycystic ovary, multiple cystic ovary. 30% of women who would ultrasound with have no symptom, no problem with her period will have polycystic ovary. So polycystic ovary only helping you to, combine with biochemistry and clinical to confirm a diagnosis, but not using solely just for the purpose of the problem diagnosis, because so many normal people have polycystic ovary. Secondly, ultrasound, abdominal ultrasound not very accurate because so much gas there, so much bound there. Gas and air and a fluid, not very good for ultrasound because they not rebound very good. They not get a better picture. Ultrasound looking for liver, looking for spleen, looking for kidney, or looking for for gallbladder, good. But if the people are obese with lot of bowel gas, and then you probably ultrasound probably not good help you a lot. Pelvic ultrasound is the best to do because pelvic ultrasound you're looking only three structures there: ovary tubes, and uterus. So a good thing to do also. CT scan for the pelvic is not very good because so much interference there. So in this case, you probably got to go back to you looking how you make a diagnosis of polycystic ovarian syndrome. It's very obviously, don't go to some rare case. And ultrasound, don't rely all in technology. I think Dr. Woon Tran said ultrasound. Ultrasound is very simple these days. Everyone can use it. A lot of people can use it. So simple, so cheap, very cheap. And intracranial ultrasound, especially we do for neonatal, the best because we go through a fontanelle. You can see all the structure. That's so easy. A skull ultrasound is not easy because you have to penetrate to the skull. So they have to use in somewhere we can see the sound wave can go through. That intraocular will go through that. It's much better, but very uncomfortable for patient to have the thing poking on their their eyes. So in summary, go again. Simple. And something need to be done, do it. Don't overstep what your transvaginal ultrasound scan is no. But people who have been sexually active, transvaginal ultrasound scan is the best. The one we have to do, always I can persuade to the patient to have transvaginal ultrasound scan. You need a chaperone, need someone to there because they stick someone into some broken vagina. You can expose to many litigation that could be mishandling. So good. I'll hand it back to Dr. Tran. Anything else you want to ask me about this one? I think next few weeks I'll talk about offset guarding. I'll probably go through more with you about this field. But polycystic ovarian syndrome is quite common in our world and become more common in Vietnam now because a lot of people start getting obese, a lot of fast food. In next 10 years will be more and more, you will see more. I've seen quite a few people who come to Vietnam now do have the polycystic ovarian syndrome now.
All right, thank you very much, Dr. Ho. So we take a break in 5 minutes and then we come back. And yes, you have a question?
Yes, I have a question. We will use the transvaginal ultrasound for the virgin patient in the US?
Well, the answer is no. If the patient is virgin, in this case, and again, when I started this discussion, I like you guys to make a diagnosis as a clinical picture. Every modality we use is to either help. It's not just solely based on that imaging technique. And this is so important. And even I said earlier, a lot of them here, we raise a lot of money and many tests are unnecessary. And I like to focus more on the basic, because as a physician, you make a diagnosis based on history and clinical exam. And whatever test to confirm is to confirm or to rule out your diagnosis. Do not solely rely on just one single test to make a diagnosis, because I'm sure you know this and you will see it a lot in your life. Normal people may have abnormal imagings, and that doesn't mean that they have problems. Okay, so we will come back with this and we'll talk more. Okay, thank you. Take a 5-minute break. Thank you. Yeah. Okay, class, let's go ahead and start it. It's 5 minutes. Thank you, Shilong. So the rest of the class today, we have 8 more cases. So each of you will have 5 minutes. Please go ahead. Tell me your name and what case you are presenting.
My case is number 3. This is about a baby, 2 years old, presented with nausea, vomiting, and crying. So the mother his mother is concerned about the radiation. So the first I was when approached the patient, I would ask her resent to perform a physical examination onto her baby, and after that I offer the abdominal X-ray. And so to handle her concern, I have to explain her information about this the investigation. First, I would say that your child's condition is quite difficult to diagnose because a wide range of disease has the condition of nausea and vomiting. So to identify the exact disease underlying, I have to offer this abdominal X-ray, because if we skip this investigation just by my physical examination and give a diagnosis, I would overlook some disease that would be fatal to the baby's life. Yes.
Such as,
and
so what
okay.
disease, what fatal, that's something that can kill the baby?
Okay. My diagnosis is about, the first is gastrointestinal syndrome that can make nausea, that can make vomiting, but it's, in most cases it cannot kill the baby. But if babies have disease like intestinal obstruction, yes, and if we don't intervene quickly, the babies his intestine would be necrosis because of ischemia. Yes, and that will harm to his life.
So you convene a mom to have the X-ray done, and the mom was concerned about radiation. How would you explain that? Hello? Shilong, are you still there with me?
Yes.
Okay.
Hello. Hello, class.
I think they're frozen.
Yes, it's no problem again.
Okay. Well, so I guess we have to wait. Let's see. Hey, class, can you hear us? Hello, class?
Hello.
Yes.
Chết bộ này không có tí, này không nghe được tí gì.
Hello.
Sorry.
Cá mập cắn rồi.
Yes. Shark bite.
Internet problem.
Mình tự mute được này.
Yeah, internet problem again.
Hello, where are you? Where are you guys?
I'm here.
Yeah, nice
Mọi người
to
đó chết rồi.
Hello. All right, we have 8 more cases, right? Too long.
We have 8 more.
How are you doing in Australia, Dr. Ho?
Yes. Quỳnh nói gì?
How's everything there? I haven't seen you for a while. How's everything?
Everything good. Nothing. Just keeping quiet. For the bad for that day. What do you mean? Just, but everything fine. We just keep it very low key. My daughter just came back from university to spend time with us, so we keep our family, really time together.
Nice. Yeah. Okay, it sounds like it's working now.
Ủa sao tắt luôn anh? Không phải, nó lên vô rồi kìa. Phải rút sang rút anh chút xíu. Đúng. Không gắn chặt rồi được. Khổ ghê rồi. Hello, can you hear me?
Yes.
Okay. Now I will list some reason to convince the mom to agree abdomen X-ray. First, it's about that it's truly necessary to identify your baby.
Okay.
We will not. Yes, the condition that is dangerous for your babies would be not overlooked by the investigation. It's okay. It's hard to be overlooked. Yes, and the second is that the exposing dose of radiation is not much. In abdominal X-ray is equal by 1 week of background radiation. It's not so much, so it's safe for your baby. Okay. And the first, I think that we have to make the parents be just into us, because we will make them. We will tell them about our trained technologies at the advanced equipment and film, so the dose will be minimized as possible, as small as possible.
Mm-hmm. Okay, so the bottom line for this test is you have to weigh the risk and the benefit. If you can convince the patient that the benefit from this test, in general, in any test, it's much better than the risk, then you're okay. I like to make sure that you know the very basic for X-ray. If for a normal person, the normal radiation from the sun equal 1 X-ray per year. So if you don't do anything, you already exposed to 1 or 2 X-ray a year. So it's okay to tell one mom, relax, it's okay. You have normal, this is the normal amount of radiation that everyone receives. Okay. Can you hear me, Dr. Ho?
I think we lost connection with them.
Oh, okay. So now just you and me, basically.
Yeah, we talk. In.
Okay. Okay, I'm good. Okay, I think I'm okay with that explanation, and why don't we go forward? I'd like to move to the next case, because I think I said it again and again, and it's recorded on the YouTube video. You should be able to see that or watch it again on the YouTube video, okay? Oh, let's have problem with it. All right, guys, who's my next case?
Okay, I hear you.
Okay, yes. So bottom line is, if you can explain the risks and the benefits like you did in this case, you should be fine, okay? In any test, it helps you with diagnosis. Do not rely just one test, but put together all the clinical history, all the information. In this case, the baby needs X-rays. If you can clearly explain to the mom that the risk and the benefit, then she would understand and you will be fine. Okay, the bottom line is, guys, X-ray is very easy, and it's it's not a lot of radiation. That's the bottom line. Explain to your patient, X-ray, not a lot of radiation. Okay, to tell them you go to the sun, you already have radiations. Just go out there and it's equal 1 or 2 X-ray a year. So that's the normal one. So any of they'll use in Panther, you go out there and every day, every year, you will already have 1 or 2 X-ray per year. Okay, so that's how would you explain to a patient.
Can I add one? Can I add one thing?
Yes.
You have to be. I think that the communication still have a little problem. Never threaten the mother with a case could be fatal or your child could die. Have to use a bit more, subtle language. You don't use those language, and we don't use them at all. what I just say, I would say, you know, this case, probably we need to help your child. We need to make a diagnosis, the right thing to treat your child. I do know that the radiation could be exposed to radiation. The risk of childhood leukemia is still there. You never say no. There's no such thing that no radiation. The childhood leukemia is still the risk there. We're still not sure what the figure are, but they are. So, but I would like you to, you know, risk versus benefit. If the benefit outweigh the risk at this stage, we need to make a diagnosis. You can help your child. It could be very difficult to make a diagnosis, but don't threaten them that your child fatal or something. It could make the whole scenery will be, you know, whole situation become inflamed. That's why you guys get been, you know, hit or been bitten by a patient so often, because sometimes we use the language a bit too strong. It's a bit more subtle. So a child could be very important. He can be very sick and very hard to treat. So they talk that way to convince the mother more. Okay, don't use so strong language there to make them really agitated. Especially if I'm a mother, father of the child, I will be angry. You know, I don't do X-ray your child. I can kill my child. It's something that very make me angry easily. Cool down, doctor, cool, and will treat them with dignity. Explain to them, you will never have problem, but have to learn the communication. No, you don't use that fatal.
Thank you, Dr. Ho. Go ahead, guys. Let's move on and to the next case. All right, go ahead. You have 5 minutes to present this case. Tell us your name and what case you were presenting.
My name is Meng. My homework is a female patient who is treating in ICU. She has pneumonia and tubitic, still on a ventilator. I check deep tubitic. So you ask me like we should the portable chest X-ray or regular chest X-ray, and why? So I think in my patient, she used portable chest X-rays because she has serious condition and she has tubitic. So we should limit to move. So I think portable chest X-ray is necessary for her because we can because it reduces risk transport patient such as respiratory failure when we bring her to X-ray department. And however, the portable chest X-rays give picture image can be limited. But we check the tip. So I think it's as good as regular chest X-ray. So I think portable chest X-ray is a good choice for the patient.
I concur. I agree that in this case you will do portable X-rays because ICU patient student, you should know that they sick and they admitted they on ventilator, they have pneumonia. So question for you and the student is, do you need to do daily X-ray? Yes or no? Do you need to do this X-ray every day, or how would you do? Like every day you come to see the patient is still on ventilator. Would you repeat X-ray? Would you do it again, or what would you do?
I check the tip when I put tip, and when I change the tip, I will check the size of tip. Is it right?
Okay, so this is the issue that a lot of hospitals in the US facing is we overuse X-rays, especially the portable one. A couple of years ago, there's a lot of people doing daily X-ray in ICU. So I just sent you on a meta-analysis link, and then they will tell you whether you need to do a daily X-ray or not. The consensus from the chest society and also the ICP is you based on the clinical symptom. So this will go back to the basic question. We are treating a patient. We don't treat an image. So the decision to repeat a chest X-ray daily in ICU, it depends on how severity the patient is, how she responds to antibiotic, anything change in line, anything change in her ventilator, anything that will make your concern that you do X-ray. If there's no change, if there's nothing else, people tend not to do it. However, in practice, I'm sure, at least in my hospital, they do daily. I don't know how in your hospital at Geelong, they do daily. Just want to make sure that. But just give you guys the idea that sometimes do an image, you have to think about how the patient will respond clinically. That's the whole thing about this case. See how the patient do clinically, and then you make a decision based on that. You don't do daily X-ray routinely because the patient in ICU. Okay, so that's, and I agree with you about the portable, which is the regular one. The portable is the one that easy to do. You can do it at bedside, but the quality of the image is not as good as the regular one. Okay, any other questions? So Dr. Ho, just give you a couple more questions that you guys think about it. And those are really good questions. So again, I note, my notes, and then everyone knows, make sure that after this class, take a look at that because they really helpful.
I have one question.
Yes. So what's your question?
If the patient in ICU, she has still ventilator,
can you repeat your question again? I cannot hear you. Just do it slowly. It's fine. What is your question?
In ICU, the patient has tubatic and ventilator. In the young hospital, the patient will check the tip every day.
Well, the answer is yes. It's likely we do that because we want to measure the tip of the endotracheal tube, and you make sure that. And actually, a lot of this has been done by RT, respiratory therapists. They like to make sure that all the ventilator on the line was in alignment. So in this particular case, yes, I mean you may do daily X-ray, but the lesson to learn from this case, you have to base on your clinical symptoms and how the patient is doing. We don't do daily X-ray because the patient in ICU. In case the patient is ventilator dependent like this one, the answer is yes, because on the line and at the lofting section, we like to make sure that. But if the patient just admit to ICU and not ventilator dependent, and you have to, based on clinical judgment, you don't do daily X-ray because the patient's in ICU. Does it make sense? So that's the thing that I like to share with you guys. Okay, so are we good? All right, so that's portable X-ray in ICU lessons, and then let's move on to the next case. Thank you. Any quick comment on this? Because this is also, I know this is your expertise. You see a lot of daily X-ray in ICU.
Yes, in my hospital, we do every day about 4 o'clock morning because chest X-ray very important for you can look everything. Look like you support thyroid. You check about ET tub. You check about retub. You check about the patient condition change or not change. Because every morning the RT with the nurse beginning weaning. We cannot wait in for the doctor come in order, you know. Yeah, it's a very important for us.
Yeah, that's a very interesting topic. Like a lot of people, especially in Vietnam, they don't test for weaning. They just put on machine forever. And that's a very, very dangerous practice. But we'll come to that some point in the future, okay?
Yes.
All right, next case, go ahead.
My name is Thy.
Okay, Thủy.
46, female with breast cancer, left confirmed by biopsy.
Okay.
My patient have breast cancer in her left side. So she may have a high risk of cancer in the same breast or even in the other breast. So to make a certain diagnosis, I recommend mammograms to detect the other early breast cancer. The second imaging modality I recommend is CT scan to determine the size of the tumor, any lymph node, and does the breast cancer spread to any part of her chest. I also recommend BET scan, although BET scan is very expensive. However, BET scan can determine if the breast cancer has spread to any part of her body. I think CT scan and BET scan are necessary to have classify the stage of the cancer and have to choose a suitable treatment for the patient.
Okay, I like it. I like your approach. So let me ask you this: how would you explain a PET scan or PET? Just call PET scan. It's called PET scan. Okay, don't have to say PET. How would you explain a PET scan to a patient? And why you think the patient is need PET scan study? How?
After biopsy, you have breast cancer. So I need to investigate carefully. So I order a PET scan to determine if your breast cancer spread to any part of your body.
Okay.
Because PET scan is very expensive. It's about over 2,000 million Việt Nam đồng. So if you can afford for it, you need to do this test. It's very necessary to determine your staging of your cancer. Is it okay with you?
Well, I think it's okay. But let me tell you, medical imaging in 1 or 2 minutes. Medical imaging in oncology and cancer, very, very important. So all of you, if you tell a patient have cancer, the #1 job in terms of medical imaging is you have to realize that what is the extent of the disease, like you say. You make sure that the other breast is okay. And the other question is, was it localized or involved to other organs? And the PET scan is one of the very good way to see if the disease, how far or any major organ has been involved. So this is how you will tell your patients. And I think it's okay. But to give you an idea, medical imaging and in fact, in the US, medical imaging and oncology require a lot of training. So I don't expect many of you know a lot about this, but just give you a taste. Dr. Ho give you guys a really good summary of the patient with PET scan and what is used to. So make sure you read. I know a lot of text, but this is basically how it works. Cancer patients use a lot of energies. Okay, just like us, when cancer patient use a lot of energies because they replicate faster than normal, so they need glucose. Think about it. If they need glucose and you give them glucose, so they uptake, they take them all, and that will light up on the exam. Does it make sense? So the PET scan actually basically it's at the glucose. So you give sugar to the patient with cancer. Now you have to know that any area of the body, high activity such as the brain, the heart, and anything that require high energy also needs sugar, right? So guess what? In the PET scan, you see brain, the heart, and all the major organs also light up if they have a lot of activities. However, when you compare with a baseline, tumors, in particularly the breast, this usually don't have a lot of activities. They may increase activities because of tumors, and that's how you can tell. We call increased metabolic activity, and that will follow. For today's lectures, I give you a quick taste how PET CT is, but this is likely a lot of information. And make sure you try to read. I mean, this is a lot of information. Dr. Hope just put it. Thank you, and Wang. This is awesome. So he gave you a lot of info, a lot of readings, but you will like it. Okay. So for this case, you're doing okay. Thank you. Any questions? All right. I think Long and Anwang, you guys still there with me, right? I think the connection is not stable. Long, you still with me?
Yes.
Okay, good. I just want to make sure we're okay because a lot of time I don't know if they listen to us, but all right, I guess we have to wait. Yeah, I don't know, Dr. Hall. You know what? This actually did not happen last time, right? Geelong, I don't think this happened last time. I think for some reason today it's
Today.
Only in your day. When
huh?
it's only on your day.
It's always my week. Actually, 2 weeks ago I was doing fine. Right, Geelong? Actually, 2 weeks ago I was doing fine with all of them. Yeah, but today it's all right. You're back. Good. Can you hear me? Raise your hand. Yes or no? Yes. Can you hear me? Okay, good. All right. So take a look at that note that we posted there. There's a lot about PET CT. You should learn about that. All right. Any other questions? Okay, good. Then we will move on to the next one. Good.
So, good morning, everyone. My name is Ngọc Anh, and my case is a 56-year-old. So,
okay, go ahead.
Okay, can you hear me?
Yes.
Can you hear me?
Yes, I can hear you.
Yeah. So, good Ngọc Anh, and I make a 56-year-old male with 35-year history of smoking 1 pack per day, and he came to the hospital for regular checkup, and I mean him for 60 CT scan.
So what?
Can you hear
me? All right, I don't really hear what the signal is really bad. Geelong, can you hear or no? It's very bad. All right. All right, Geelong. So why we here? I'd like to share with you a journal from a chest physician. Basically, they against daily ICU X-ray.
Yeah.
So I know that, but both ACP and the chest physician. I'm an ACP member, so I follow my guideline. We don't recommend that, but it's okay. I think in clinical practice, it's sometimes you have to flexible, and it depends. But the chest physician, they go against that. They say no. All right, class. Oh, it's very difficult.
We have 4 more cases.
4 more cases? Okay. I think after today, Jilong, if we can ask the class to see is there any way that they can test the platform, the technology before the class starts, that would be great. Otherwise, this is a lot of downtime, and we have a lot of downtime.
Yeah. Em có tin là hồi xưa email của trường mỗi lần mở ra là bị kẹt mở không được. Nhất là ngày thứ Bảy, Chủ nhật cao điểm sử dụng Internet là người nào sử dụng email của trường Đại học Cần Thơ là không có vô được.
Oh my gosh.
Yeah.
Today technology is...
Yeah.
Okay. We have 4 more weeks nữa from Jilong. How many more weeks? I think Dr. Hall will come back next 2 weeks.
Yeah.
And then we approach to the final.
I have the schedule.
We almost there, and where? We're almost there. Can you hear me? I said we're almost there.
Yeah.
We're more than halfway already.
1, 2, 3, 4, 5. We have 7 weeks more. Oh.
Yeah.
The next wish for Dr. Mindo. Dr. Min. More people.
Cảm ơn nha.
Okay. Ngon không anh Quang?
Hả?
Ngon không? Oh my gosh, chỉ còn có 2 anh em mình.
Cuối năm đi Germany, có ghé Sài Gòn vài ngày.
Wow, tháng mấy?
Tháng 12.
Tháng 12 hả?
Không biết làm gì nữa. Chán rồi.
All right, so why don't you we always organize another medical English class in Vietnam for us.
No more come up.
Yeah. So I'm so sorry for that convenience because so
okay.
my case is number 4, and what I would tell to convince the patient of mine. So he came to the hospital for the medical checkup, and after taking his medical examination, and I have his medical history for like smoking for like 35 packs a day. It means more than 30 packs per year, and his age is 56. Therefore, he is on the high risk of lung cancer, and I will and because you're smoking a lot, and you know that in tobacco that have like nearly 7,000 chemical, which is 50 of them can cause cancer. Therefore, I advise you to take a low dose CT scan to check to screening whether if they have any problems in your lungs. If yes, we can detect it soon and we can treat it as soon as possible. That would be good result to you. So do you have any questions for me? Yeah.
Yes. How would you explain what's low dose CT versus high dose? What low dose means?
Okay, so prepare for that. Okay, so the low dose CTs mean that the dosage of radiation that that we give on the process to taking your CT scan is low, is really small, that wouldn't affect your health too much. But the high dose will like a large amount of radiation. It would not affect your health. So don't be worried to take in the low dose CT scan.
It's okay. I like it. I like the way you explain. And what you can say, the risks and the benefits. Again, class go back to any test. You talk about the risks and the benefit of not taking the test versus taking the test. In this case, the CT scan will involve radiation, but it's a low dose. What it lows compared to a regular CT. And this will make the patient feel a little bit better because it's the radiation that's less. Now, the significance of that is there's a lot of arguments about that. And I think Dr. Paul already posted online some of them right here. But bottom line is, if you can detect cancer earlier, especially in Asian, this has happened a lot in Vietnamese men. In Vietnam, they smoke a lot. They smoke like chimneys. So if you can at least convince them, hey, you know what, you should worry about your lung cancer. That's a good step. Whether they agree to go with low CT, even better. But tell them the risk of cancer with smoking, that would be a good one. And so this case, basically to tell you about awareness of there's a utility out there called low CT, and it could be useful. Again, I would not go further like how you interpret a lot of them. I mean, this year of debating in the US, and I'm sure in Australia and other countries too. But for now, the ACP, the American College of Physicians and the Chest Physician Society, we support this guideline. And things can change. So I don't know how about next few years, whatever. But for now, we recommend low dose CT for people actively smoking or quit with the past 15 years, and if they smoke more than 30 years, and is it men between 55 and 75. Okay, so those are the guidelines. You don't CT everyone, but there's a guideline, okay, and there's a high risk patient. Yeah. Okay, so that's a good one. Bingo, I like your English, and you clearly demonstrate that you are able to explain to the patient. Okay, keep continue with your Wednesday lecture. I like it. Okay, you guys keep doing that, and I will join you guys soon. Thank you. Next one. Hi.
Hello.
Okay, so tell me what case are you presenting and what imaging? Tell us about your case.
My name is Keith. My case is number 8. This is about a 53-year-old patient. He came to the hospital because left side weakness. He has a history of smoking and coronary artery disease. What the imaging I do first and second, I think in this patient, he gets a cerebrovascular disease, and there are two types of cerebrovascular disease. It's ischemic stroke and hemorrhagic stroke. The first I will do the CTs, the cranial CTs, to distinguish two types of stroke, ischemic or hemorrhagic. Yes, and in this patient, he comes to the hospital because of the symptom left side weakness. There is the only symptom of this patient, and he had a history of smoking and coronary artery disease. So I think in this case, he may be at risk of embolism or thrombotics. And I think he can get ischemic stroke.
All right. So the first imaging modality you say was CT, right? The first one was CT. Oh, I think they. Well, I think they may have a CVAA. Okay, you're back.
Sorry, can you hear me?
Yes, I can hear you. But now I cannot.
Can you hear me?
Yes. Hello. All right. So Jilong, actually, I have to go around 9 p.m. So I'm not sure if we can finish this, but if not, then I will do a class. I do a presentation on video on YouTube, and I will walk you through the rest of the case. But I will do a case summary later with all the cases. Can you hear me, Jilong? Okay, good. Have you been to Los Angeles recently, Jilong?
One time, long time ago. Yeah.
Chị có định xuống LA chơi nữa không?
I'm not.
She come to West Hollywood.
Okay. When the last time you come to the US, Anwar?
I think I went to Seattle about 2 years ago, and Los Angeles about 3 years. But in September, on the 2nd of on the end of August and first day, I think Labor Day in US, I will be in LA for the high school reunion, 40 years. But I probably only there for 3 days and fly back. So I study at school Con Nguyễn Thượng Hiền ở Sài Gòn, and we have a reunion 40 years.
Wow.
I'll be there for 3 days only. Fly in, fly out. They normally organize at the restaurant called Diamond in Little Saigon there. Every 2 years we have a reunion there.
You come in San Jose too, but you did appointment with me.
Yeah, no, that day I got stuck in traffic for nearly 5 hours. As I told you, can't move, and rainy, and I'm driving in different way, different side of the street. So terrible, it was terrible. I couldn't, yeah. It took me nearly 5 hours to come back to San Francisco. It's too long. I went at the wrong time of the day. But I've been to US a few times. I like New York. I like the Seattle. But LA a little bit too not very attractive. Yeah, San Francisco, beautiful. But Los is just too much, too big, and too much traffic, and not much to do. They lost its connection now.
They lost connection already. We have for
I'm so sorry, it's because some problem with the Wi-Fi connection.
Mấy chiếc tàu ngầm mua đâu rồi? Cắn hoài vậy.
Dạ bắt chưa được cá mập. In my case, the first images I will do is radio CT. Yes, in this case, I think we need to distinguish between two types of stroke, ischemic stroke and hemorrhagic stroke. After having the result of CT scan, we can distinguish ischemic stroke or hemorrhagic stroke. If the result is hemorrhagic or ischemic, I think that we don't need to. If the result is exactly of ischemic stroke or hemorrhagic stroke, I don't think we need to take the second imaging. But if the result of the CT scan is not exactly, I think if the result is not exactly, I think we should conduct MRIs, radio MRIs. Yes, because in some case, if the patient has the low Skinner syndrome, we can see the lesion in the CT scan, so we must conduct MRI to detect the lesion of low Skinner syndrome. Yes, and if the patient gets hemorrhages in CT scan, I don't think we need to conduct the second imaging. But if the position of the hemorrhages in CT scan is not typically for the scale of hypertension, I think we should conduct MRI to diagnose what the arteries of the trend is.
I'm good. I like your approach because if this is hemorrhagic, you don't need to do an MRI. But if it's not hemorrhagic, then you can go ahead and do an MRI of the brain. Now, a lot of questions that they will ask you about, so when you do MRI, you do without contrast, or you do with contrast. What would you do?
I'm sorry, I can hear something you have to speak.
When you order an MRI of your brain, you do with contrast or without contrast?
When nói lớn I can't even hear you.
Well, what I'm asking is, if you order an MRI of your brain, would you do with contrast or without contrast?
I'm sorry, could you repeat again?
Go on, chị John, can you hear me?
I'm sorry.
If you do order an MRI of your brain, would you do with contrast or without contrast? Let me type it
out. Yes, I think if we need to take, yes, I think if we need to take MRI to diagnose ischemic stroke, I don't think we. I think we do need to take the contrast materials. Yes. Yes. If the patient goes to the hospital and we suspicious about the tumors, in this case we will the contrast materials. And if the patient we are interested about the stroke, I don't think we need to take the contrast materials. That's my answer.
Excellent. I like it. Very good. All right. So when you get order a CT or MRI, think about with or without contrast. And yes, please check your pronunciations because ischemic stroke, cardiovascular contrast. So those are the terminologies that you should be familiar with. All right, next one. Good.
Thank you.
Hello. My name is Nong, and my case is about 70 years old female presented with shoulder pain, not able to abduct, and not responded to conservative treatment, and her shoulder X-ray is negative fracture. So I think that the cause of her situation here is the problem with the soft tissues and tendons or ligaments. Okay. So I think that I have to imaging test for her. The first choice is ultrasound because it is cheap and fast and convenient and not exposure to radiation and no invasive. Ultrasound in the shoulder joint, we can find whether the arthritis, shoulder arthritis, or bursitis, complete rotator cuff tears.
Very good. I like it. How about X-ray? Would you still do X-rays? Actually, did I say X-ray before?
Because X-ray is negative rupture, and X-ray is it's difficult to see the ligament or the tendon. So I think ultrasound or MRI is better.
Okay.
The second choice is MRI, but it's a very expensive, and though it's better for us to diagnose the problem of the patient problems, but it is very expensive, and it can has 95% of sensitivity and specificity,
in detecting the basal thickness rotators.
Okay. Now, good job. I
Yeah.
like the way that you present with start with clinical information, and then you know about ultrasound. So if the ultrasound is negative, then yes, you can proceed with MRI. Now, ultrasound depends a lot on the operator. So whoever scanned the machine, you should know that. So this is one of the limits of the ultrasound. For every modality, you guys should know what are the pro and con for each. So ultrasound, one of the limits, one is the operator dependence. It depends on the experience. You may or may not get the best image quality, and that will impact to the interpretation results. Okay, so I like it, and this is a quite classic simple approach impingement, injuries, and ultrasound is really good modality to start with. All right, any questions now?
I have one question.
Yes.
If the patient is not responded to conservative treatment, what we can do next with the patient?
Okay, so if you do ultrasound and MRI, and let's say if you found a rotator cuff injury and even with rupture, study show that conservative treatment is still better than surgery. However, if the patient not respond to conservative treatment, and what I mean conservative treatment by physical therapy, pain control, physical therapy play a big role in rotator cuff treatments. So you have to send to a good physical therapist. If not, then you will talk to the orthopedic surgeons and see what ligaments or what problem with the tendons. In this case, you can do a fix, or you can do a rotator cuff. They try to detach, or they even tie them up. They can do open, or they can do intra. What they do is they do endoscopy. Okay, go ahead and wax.
Got a few practical point here. First of all, I have to make the sometimes you look at the report or X-ray. It's best to look at by yourselves. Sometimes the report could be inaccurate, but a good thing for you to look. If you suspect something why the patient not improving, you can ask the radiologist to look at X-ray again. Sometimes they reporting hundreds a day. They easy to make mistake. So the best thing to get a practical point every time. If something you need to look at yourself, don't rely on just the report in front of you. Look at the film yourself and get familiar with it. Secondly, when you refer for the X-ray, ultrasound, or MRI, you need to have a list of the place you know is trustworthy, or the one you're familiar with, the one you can communicate with them. So you take those lists, because so many people can advertise, they can do multiple things. But what in my practical point of view, I have the list of people who I trust, where I know I can rely on their report. So I will choose some. I'm not getting a kickback. I don't get commission, but I know that I'm reliable on that report. And lastly, if you're unable to treat the patient, you always the best way in medicine, you get a second opinion. Never hold the patient, never feel that lose faith that you can't treat the patient. It's always there someone better than you. Or maybe you're better in one field, but other people can be better than you. To refer them to physio, to orthopedic surgeon, they get reconstruction, whatever down the track. If you're not sure, you can't do it, move on, get to someone to help them. If the other guy said no, they can't help, that at least you have asked, second opinion. So that's a three practical point in practicing safe medicine. First of all, look at by yourself. Secondly, you know who can do that, X-ray modality for you. Number three is just, get someone else's opinions if you're not sure.
Thank you very much, Anwang. And good job, Ngân. Move on to the next case.
Hello, doctor.
Yes.
My name is Thing, and my case is number 5 is about 67 female presented to follow up at a BCP office. There are 2 questions. The first one is, would the daughter like to do a DEXA scan on her mom? And my answer is yes, because I think the mom needs to have a DEXA scan because it can help to diagnose the osteoporosis with DEXA test, and following the guidelines, and is it recommended that a woman who is 65 or older need this test? Yeah. And the next question is, the result come back with the T-score is negative 2.7, and what will I do? And the T-score shows that the amount of bone someone has is compared with the young adult of the same gender with the bone mass, and this score, if it is above negative 1, is it considered normal? And in this case, it's a negative 2.7. It means it's a lower the negative 2.5. And I can say that the mom has osteoporosis and she needs treatment.
So what treatment you going to give her?
Yeah, as the guidelines of National Osteoporosis Foundation, it is strongly recommended that we can use some medication to help reduce the risk for hip and vertebral fractures, as aleuronate, risedronate may be used. Besides that, this treatment needs to last at least for 5 years, and with all therapies, we should give the patients with calcium and vitamin D. With about calcium in the woman who is 50 or yeah.
Yeah. So it's good. So you start with the suspect of osteoporosis, and you did this test and you confirmed. Now, what happened after 5 years? People taking alendronate. What are you going to do next?
Yeah, because when we use the medication to help to decrease the risk of fracture in patient, and I think after 5 years of medication, we need to evaluate the PMD again with the DEXA scan.
Okay, good. So one last question for you. How would you explain DEXA scan to a patient, to someone new to DEXA scan? What is it?
Yeah, and maybe because is in this test, the T-score of the patient is negative 2.7, and in the 5 next years, I hope to this index may be higher. Yeah. So it in the limit of between negative 2.5 and negative 1.
Okay. What you can tell the patient, basically just say this is a test that we usually focus on measuring bone density on the lumbar regions, and then also on the femur bone. So those are 2 bones, the major bone and the hip, to evaluate risk for fracture in the future, and also a diagnosis of osteoporosis. The DEXA scan has been performed in multiple locations, but by far the two most common sensitive and reliable in the lumbar and the femurs. You will see that it's done on the wrist, sometimes even on the thumb, and also on the talus, on the one of the larger bone in the foot. People do different way, but for Medicare purposes, the only two one that reimbursement is the one in lumbar and the one in the femur. Now, this test has had some limits, like Dr. Wang just said. You have to realize that every test class, every test has limits. You have to know what are the limits. It's not, there's no perfect test. Dr. Wang mentioned here a couple limits already. So I'd like you to follow up to read that after today's. All right. Any questions?
And I want to ask, because if the patient have the ruptures, so we need the X-ray. So in this patient, she haven't have any fractures, so X-ray of the spine or the femur is needed.
Yes. Here's the thing. A lot of people, they have.
We check for the.
Yes, many women, they have fracture and they don't even know. Okay, so some of them have a minor, we call compression of a wedge fracture. And this is someday your mom or your grandmom become kyphosis. They stay like this and they go like this. And a lot of time they have a minor, tiny fracture that they don't know. So I recommend that when the people become osteoporosis or their skull is wrist, especially if they have diabetes, they are PPI, they are steroids, I will do X-ray, I will do DEXA, also check vitamin D level. A lot of those lab tests just to make sure that evaluate the risk for bone health, include fracture. Because if you can prevent a fracture, that will love you. Okay. Women come to hospital because of fracture, because of fall. 50% of them will die within 3 years. That's a very high mortality, and you don't want it. Dr. Mindel did a really good journal club a couple of months ago on fractures and how to prevent them. Okay, any other question? Yes, Nguyen.
I think with the treatment, you have to be, you guys jump so quick to bisphosphonates. You got to look a bit more global picture. You use the best medicine. Biphosphonate, you have a lot of side effects. You can't just simply use it. You have to look at patient why she developed osteoporosis, what the lifestyle, she not have enough vitamin D, she not take enough calcium, or get a family history of osteoporosis. You look at that old picture, to treat them, to manage them first before you jump straight to biphosphonate. Biphosphonate, so many. What happened to calcium? What happened to vitamin D? A lot of people now, they don't want to export. In Vietnam, probably vitamin D not a big problem, but in our, other country, the vitamin D in Korea, the vitamin D deficiency is very high because we afraid of sunlight. So again, this is a general case. Every case, because look at the global picture before you jump straight to the best treatment. Biphosphonate, of course you need it, but you got to be careful before you jump so quickly, and you lost all the other side, lifestyle changing, diet, people overweight, all many things other affecting other. Most people, these people will have a multiple, medical disorder too. You have to make sure, they're okay too. To be that way. Just my little add. Okay.
Thank you, Nguyen. Thank you for that insight. All right, next case. All right. Okay, go ahead. Is it your last one, or I have one more after this?
My case is number 9.
Okay, go ahead, please. Yes.
My case is a female. 26-year-old presented because of her symptoms about.
Excellent. Very good. Yes.
Past medical medical history and family history. Check her therapy. That I will give her a laboratory test. Before giving her the image test, I will give her. I will measure the level of thyroid hormones such as TSH, tyrosine, and active free. About imaging test. First, I will give her the to patient the number of scan. I will follow up, and if it is larger, I will give her the sonography.
Okay.
Sorry for interruption. Yes, and then I will give her. I will give you the sonography guide FNA to distinguish between benign or malignancy nodules.
So this is a challenge question for you. How big the needles you will use for the FNA case? How big the needles?
Is about 1.5 millimeter.
0.5 minutes. Tell me in French. You have the number, right? It go from 18 to 30. So what gauge? What number?
30.
Okay, so this is something that you go home and study, okay? Because this is important. You tell patient, oh, you know what? We're going to take a biopsy. We call FNA, so fine needle aspiration biopsy. But you should know how big the needle is because it actually is quite big. So usually, what they do is you 18 or 20, and under ultrasound guided, what you do is you palpate like this, and then you take it out and you look under microscopy at the slide and you see it. So it's a little bit discomfort, and you should know that. So to explain to the patient, this is not a fair question for you, but just for you to learn more about this procedure, because when you do ultrasound of the thyroid and do a biopsy, a guided FNA, this is what it is. Now the protocol, I think Dr. Wang Ho just sent you a review how to do this, and they will show you guideline, the next step, nodule, and then to scan hot versus cold. Okay, if you're a hot girl, what you do? If you're a cold girl, what you do? That's how I remember. And now based on that, the one thing about ultrasound in thyroid, and this is important, is the patient, a lot of them, they in the US, many of them are really big. So if they obese, you cannot by hand examine it and you cannot feel it because they have really large neck. In this case, you definitely need ultrasound to evaluate if there's any nodule. And I concur with you, this is your lab test and what you should do. But you should base on picture, a clinical picture, what are the symptoms patients start with, and then your imaging is a guide for you to make a decision. Okay, any questions here? Okay, yeah. That's not English, okay, but it's okay. So class, I don't know if Anh Wang or Chi Long, you might have any more comments before I say a couple things about imaging. Well, so while we wait for a class, I'd like you to pay attention in this 5 minutes because this is important. No matter what medical imaging you use, think about patient. This is a lab test and you use to aid to help with your diagnosis. do not ever rely solely on medical imaging to make a medical decisions. As always, put patient contact into your case. Just like what you just present your thyroid case and all the case about cancer. So make sure that everyone up to today, you should realize that medical imaging is a tool for you to help with your diagnosis. Okay, and I think next time I before the class, make sure you get fixed the technical problem. This is quite annoying. We have a lot of downtime today. I don't want to see that again in the future. Okay, anything else, Anwar and Jilong, before I conclude the class? You okay? All right, so see you next 2 weeks or 3 weeks. Okay, thank you, class.